Thank you very much, Madhukar, for that warm welcome and incorrect welcome, if I may add. So, good afternoon or good evening, everyone. I thought I should just create some drama because my topic may be boring for some of you, and especially coming on the heels of Dr. Namrata Sharma. So, obviously, I have tough competition after Sayan and then Dr. Sharma and all the other speakers. So, I'm going to take you through scleral inflammation. For some of you, it's snooze time. But for the rest of you, if you're like me, then you're going to find it very exciting. So I'm going to only take you through something that is what is different or what is new in the field of scleral inflammation, and that's what I'm going to talk about. So a little bit more about classification, a little bit more about investigations or the philosophy of investigations, and a little update about management, just to keep it clean and simple. So about the classification, almost everyone in this room would be very familiar with the classification that was given by Professor Watson and Sohan Singh Harry way back in the 70s when they published it. So that classification still holds good. That's the starting point. Whenever you see a patient of scleritis, think about whether it's infectious versus non-infectious. If it is infectious, then think about whether it's anterior or posterior. And then you have the necrotizing and the non-necrotizing. So what is new here is that we've noticed that you can have patients who may have either a tumor in the body or a tumor in the eye or in the conjunctiva or sclera, which masquerades scleritis. So we wanted to add a masquerade as well to the term of infectious, non-infectious, and then masquerade. And the second addition that we thought that it kind of makes sense to us is just like you have a panuveitis. So you can also have something when the scleritis is so profound that you have both the anterior and posterior segment involved. So we would like to add this term as panscleritis. Of course, from the original Watson's classification, the other terms which other authors have added is necrotizing, included surgically induced necrotizing scleritis and surgically induced diffuse scleritis. So this is not my contribution, but these two are something new that we wanted to share and publish. So what is known about episcleral inflammation? That it's much more common than scleral inflammation. And we know that classically there is lack of pain, there is blanching when you add phenylephrine, whereas in the case of scleritis, the patients may come in with some systemic disease already, and they always have severe pain. So, and then the congestion itself is very deep. So if you have a patient who comes to you where you have a sort of a doubt that could this be scleritis versus episcleritis, at least in my clinic, when we use the diluted phenylephrine, most of the vessels will go away. So that most of the time you're on the right track that this is episcleritis. I like using this test. So luckily, scleritis is extremely rare. In fact, in the Indian context, we found this even more rare than perhaps what is described in Western literature. And what we found different from Western literature is that the infectious cases may vary almost from 5 to 18%. So based on where you're practicing or the population of patients that you see. So just watch out that 1 in 6 patients that come to you with scleritis may actually be harboring an infection. It may be an infectious cause and not an immune-mediated cause. So we published our big data on this topic, which got us this incidence of scleritis, as I mentioned earlier. And the differences we saw that we had patients who were slightly younger, and we saw that the nodular cases were almost equal to the diffuse cases. But the most important finding that I'd like to say is that we saw the systemic association, the grave systemic diseases, in only 6% or less patients. So why this difference? Is it because the literature published is inaccurate? Probably not. It's mostly because the publications that are overseas are from institutes. So overseas, many of the complex cases are often managed locally, and then the more complicated cases or those that need, say, rheumatological workup or rheumatological tie-up are the ones that are managed at the tertiary care. So that could be why when the institutes publish their prevalence of cases, they might say that the systemic association is very high. So for us, in our context, I think that many practitioners are a little uncomfortable handling cases of scleritis, and they may be referring these patients, correctly so, very early to larger centers. So it's also possible that maybe there's a true difference in incidence as compared to the Western versus Indian population. But one important thing is that maybe our testing is inadequate, and that's why we're not able to detect patients with systemic immune-mediated diseases. So that goes on to the next question of lab investigations. When? So in the case of episcleritis, I would say that in my practice, I almost never do, hardly ever, unless it's extremely persistent or recurrent, and it is a cause of concern for the patient usually. And also when I have a doubt whether it's scleritis or episcleritis, or if the patient comes in with a clear-cut systemic history. So that's the only time when I would investigate episcleritis. On the other hand, all scleritis that I diagnose, I investigate. And in case the first round investigations are negative, I'll repeat those tests. Those patients with bilateral scleritis. So this is a patient who presented with necrotizing scleritis as well as peripheral ulcerative involvement of the cornea. And after multiple rounds of investigations, finally, we detected that this patient has ANCA positivity, and also later on went into pulmonary complications related to granulomatosis polyangiitis. So we need to repeat tests, especially in unilateral necrotizing cases. We need to repeat some of our testing because these patients have a much higher incidence of systemic association. On the other hand, suspect infection, if you have patients who come in with history of trauma or recent surgery, as I said that you may have 1 in 6 patients walking into your clinic with scleritis who actually has an infection. Coming to which investigations, of course all the routine investigations because we want to rule out the standard infections or comorbid infections, not associated with scleritis, but the ones I've highlighted in yellow are the ones that will help us towards an etiological diagnosis, and some of the ancillary investigations that I've listed here. So in other words, how do you classify the investigations? And in my mind, I classify them as those investigations I need because I need to manage the patients, those investigations I need because I need to ascertain the etiology. So in this list here, the top one is what I would do, whereas the ones that I've highlighted in blue are the ones that I would leave to the rheumatologist, because once I get any of these investigations positive, especially RA, anti-CCP and ANA in female patients, and CNP ANCA in male or female patients and urine examination, if I get anything positive here, I'm going to refer the patient to a rheumatologist as well, because there would be a systemic implication of positive testing here. So that's why these are not left to me, but to the rheumatologist. And then I have local investigations, whatever I have with me. For example, now ASOCT I use in most of my cases of scleritis. You might want to do UBM or B scan where relevant. And where we're suspecting infection, of course, do microbiological workup, and including rarely you might have viral inflammation. Dr. Merle had given a very good talk earlier on HSV, and sometimes they can come and present as scleritis, but it may be virus after all. So coming on to the role of anti-segment OCT in scleral inflammation, you don't need this tool, but if you're a cornea specialist like me, you anyway have this tool, and I found that it really helps a lot. So this is what a patient would look like clinically. So this patient has severe pain. When you look at the eye, it doesn't raise your antenna, is this scleritis or episcleritis? Some of us may have a doubt. So when you do the OCT, what you see is, so this is the anterior most surface, the tear film, then you have the epithelium followed by the conjunctival, episcleral, superficial, and then deep plexus. You see it's very distorted, so that can happen in episcleritis, but also the lower layers. So the limit of the ASOCT is not more than 1000 microns. So the lower layers will appear a little bit sort of not very obvious, a little obscured. But you'll notice that there's disorganization of the architecture, that everybody would agree. So this patient was a case of scleritis, not episcleritis. Started the patient on medication, and you can see that clinically there's a lot of resolution. And the OCT also shows satisfactorily that there is resolution. So you know you're on the right track for these patients. So this is a month later, I guess, that there is even better clinical resolution, but you still notice that there is some fluid, some distortion here. So this is another patient. If I show you these pictures, you're not sure, if I don't tell you symptomatology, whether this patient has episcleritis or scleritis. But you'll see that the site of the inflammation is mostly anterior, and there's a lot of fluid collection here. And although it's a little harder to see, but the posterior portion of the sclera or the scleral part of it itself looks uninvolved. So this is a case of episcleritis. So sometimes it helps to differentiate between the two if you have a doubt. And the last utility of this tool is to monitor the response to therapy. So here was a patient with herpes zoster who also had viral scleritis. And this was how the patient first came in with this nodular area, and beautifully corresponding OCT shows this elevation kind of a lesion. So a lot of thickening here because of the scleral tissue being inflamed or edematous. And as you start the patient on therapy, you can see that the images also shows you that the patient is getting better till you have almost restored the anatomy back to normal. You see this high reflectivity. This is post-edema. So you have this very high reflectivity. It takes several months for this to come back to normal. So a slightly complex slide in the last 30 seconds on therapy. So how do we treat these patients? In my practice, I hardly get away with just using NSAIDs, either topical or oral, and expecting the patient to get better. Most of the time, I start off my treatment with systemic steroids after investigating them, of course. And some of them may get better. So in those patients who are not the bad variety, like is, let's say, one eye with diffuse anterior scleritis, I start off a course of topical steroids. And some of them get better, and if they have small recurrences between, we can maintain them on non-steroidal inflammatory therapy. However, if there's poor therapeutic response, or if it's a more grave disease, then definitely you'll have to start them on immunomodulators. Luckily, although we start most of our patients on methotrexate, and many of these cases are recalcitrant, so we do have a huge lineup now of other agents. So my course would be short course of systemic steroids, start off methotrexate almost simultaneously, and if the disease doesn't get control, I would usually go into one of the biologics. It's a very simplified way of putting it. Of course, there are lots of considerations to be taken when you talk about therapy. So that's all I had for you. I hope at least some of you didn't fall off to sleep.
That's a wonderful overview of scleritis, Somasheila. It's always my bugbear, and I keep referring all my cases to Somasheila. And thank you very much.
Thank you.